Good morning. I know it's always a little bit hard to get up like this in Vegas, particularly if you go to restaurants at night. We ate at the faculty, there's a couple of faculty last night, went to that Oriole or whatever it is up there with the 5-tiered thing with Tinkerbell going up to get the wines. And the dinner took like 3 hours. By the time we got home, I was like dead. We're going to talk for the next 30 minutes about knee abstracts and talk about knee exam and knee papers and what they tell us in emergency medicine and primary care about the evaluation of people with knee injuries. Now, Steve Colucciello, who wrote this chapter, didn't get the whole plan. We were supposed to write focused little chapters that had somewhere between 20 and 30 abstracts. This one has 69. So I don't really know what he was thinking. But we're going to try and jump through. I'll try and pull out the things that I think are a little bit new about knee exam and knee management from there. Having noted that, there's two things that you can't talk about knees without getting to right up front. And the first thing is there are two types of knees. There's the acutely injured knee that you might see in an ER or an office practice, where the knee is big and swollen and sore, and it was hurt within the last 24 hours. And oftentimes people will limp around on a knee for a day or even 2 days before they seek care. But that knee is too painful to really examine without some sort of assistance to do so. If you just take it natively, and even if you're pretty gentle, you can't really examine that knee very well. And you end up with one of my favorite diagnoses in medicine, which is internal derangement of the knee, like it sort of needs psychotherapy. You're going to review it for, refer it for analysis, and you'll look at, knee dreams and things like that. And then the other thing that's hard to get away from is that even if you go to the orthopedic side and look at what orthopods do with knees, there's a huge schism in the orthopod management of knees. So there's one group of orthopods that believes in early surgery and early arthroscopy and early intervention within a week or so of a knee injury in an adult, and that will improve their outcomes. And then there's another whole group that says, we just don't believe their literature is that strong, and our management is to let the knee cool off 3-4 weeks, and then we'll decide what needs to be done at that point based on the patient's functionality, what their lifestyle is, etc. And it's really hard to reconcile those two big areas in the literature. And there's if you were to go into the orthopedic literature, there are hundreds of papers on each side. I don't think there's convincing evidence myself that early intervention on knees makes a big difference in terms of early, within the first week arthroscopy or a surgical intervention. But there are those who believe it fervently. Now, the first issue with these is how much does the history help you? How much does the mechanism of injury help you? And there's a bunch of papers in here that all kind of confirm that it's okay, and you should take the history and you should do the physical, but depending on how acute the knee is, the physical will be of less value. And the history may or may not tell you things. And one of the things that comes out about these histories and physical exam findings is that none of them are quite as absolute as we'd like. So an example of this is, we've all been told a locking knee is one of the best exam things. I mean, if a knee really locks, that means that they have a joint mouse or something physical in the joint, or they have a meniscal tear where the bucket handle of the meniscus grinds into the joint and physically prevents the joint from moving. And we think that's a pretty reliable identifier of those two things, and it's one of the most obvious exam findings that you'll ever have. Yet when they take those people to the operating room and they anesthetize them, about 20% of them don't have a locking knee. They had pseudo-locking. And what causes pseudo-locking is they have a near complete ACL tear as their injury, nothing to do with the meniscus, nothing to do with a joint mouse. And as soon as that person goes to load that that cruciate ligament up, they realize that it's really hurting them, and their hamstrings go, "No, don't." And so on exam, it really feels like you hit a physical obstruction, but all it is basically involuntary guarding, not of the abdomen, but of the knee. And so the knee is a relatively unstable joint, which depends a lot on the large muscle masses around it to protect it and to keep it strong, and it involuntarily guards. So even things like locking are not that helpful. So here's the things that if you look through the papers in general that you'll find that tell you about history and some of its value, all of it with caveats that even locking isn't 100%. And they say that twist, hyperflexion, or giving way, someone says my knee gives out, that tends to imply that there's a meniscal injury. Locking, we just talked about, tends to imply a joint mouse or a meniscal bucket handle tear. Pain on sitting or going upstairs tends to imply patellar pathology and subpatellar chondromalacia. Femoral condyle pain on either side usually indicates the broad insertions of the medial or the lateral collateral ligaments, and so those are worth noting. A massive effusion implies, in most patients, someone comes in with a huge grapefruit of a knee, implies they have an ACL, but when we look at the Hemarthrosis papers, you'll see that even that's not so reliable. So just a big effusion saying, geez, that's probably an ACL, not so good. And then there's O'Donoghue's terrible triad, one that you kind of need to know, which is where someone has a planted foot, they get a blow laterally, the knee goes into severe valgus deformity, and they blow out their ACL, their MCL, and their medial meniscus. And the reason O'Donoghue's terrible triad is important to anyone in primary care or emergency medicine, as an example it's important, is because it reminds you that a lot of acute knee injuries aren't a single injury. So the concept that I'm examining the knee to find their ACL injury just may not be true. You're looking for their ACL, their MCL, their meniscus, and many of these injuries are multiple. When the knee really gives out, more than one thing goes. The whole house of cards comes down, and there's often multiple injuries in the same knee. In terms of x-rays, as you know, everyone in here knows, most times you get a knee x-ray, I mean, it's either obviously a femur fracture, or you're worried about something like a tibial plateau, or the knee x-rays are by and large negative. With two little exceptions, although they're not common, they're very, very important x-ray findings, and they come up recurrently throughout these 69 papers, and that is the second fracture, which is a fracture, a little fracture fragment hanging out. It's a little fragment that hangs out just above the proximal fibula. And you're like, well, I don't know where it came from. Is it an avulsion off the proximal fibula? Is it an avulsion off the plateau? It's actually an avulsion off the plateau. And the significance of a second fracture is when you see a second fracture, 95% of the time the ACL is out. So that little fracture fragment hanging out there tells you that the ACL is out. And by the way, there's a reverse second. If you see the same kind of fracture fragment on the other side, then it means that the PCL is out. And then finally is every once in a while you'll see someone who looks like they have an ACL on exam, or you think they have an ACL, or their history suggests an ACL, and on x-ray you'll find that they've avulsed their tibial spine completely off. So the ACL itself didn't tear, but it pulled the whole bony process off. And that's really quite important to identify, even though it's uncommon. And the reason it's important to identify is because in adults, bones heal, ligaments don't. And so if you have a major ligamentous injury like the ACL, and you have the opportunity to exploit bony healing, then you should, and that should be screwed down with a cancellous screw into the tibial plateau as soon as possible so that that can heal. So those two fracture patterns are kind of worth noting. All right, let's talk about what does hemarthrosis mean. There's a bunch of papers on this, and they talk about it in adults and in kids. If you look at abstracts 10 and 11, so 4 through 11 all deal with this issue of hemarthrosis. They all say this. First off, what does a hemarthrosis mean to you? First off, it means nothing to you unless you tap knees every once in a while for that, because otherwise how would you know what the big effusion is? You wouldn't know if it was bloody or not. Now, in emergency medicine, I will tap knees fairly frequently, not a lot. You know, by fairly frequently, I mean maybe 5% of the time, 1 in 20. Someone comes into the emergency room with a huge knee, a lot of pain, joint capsule distension, their x-rays are negative, they can't bear weight, they're in agony, they've had a couple of Dilaudid in the emergency room. Then at that point, I think it's appropriate to stick a needle into that joint. You'll take 200 cc's of blood off frequently 200 cc's. And then you'll manage them. And by the way, once you stick a needle in there, if you're going to be in the joint space, I believe you should put some bupivacaine in there as well. Once you get the blood out, then I'll put 10 to 20 cc's of bupivacaine, 0.25% back in the joint, which will give them a lot better pain relief. By the way, they don't rebleed. People always say, don't they rebleed? No, they don't rebleed. These are small vessels. They're spasmed off. They're clotted off. They don't rebleed, assuming they don't have a coagulopathy or on something like that. I mean, if they're on Plavix or heparin or things like that, they might rebleed. But a normal, young, healthy adult does not rebleed back into their joint. And then you can put them in their knee immobilizer and do what you want to do with them in terms of managing them down the line. And that will help them because one of the big causes of their pain is the distension of their joint capsule. And that real joint capsule is particularly, if you're not sure how well innervated joint capsule is with type 4A pain fibers, just dislocate something small, like your finger, and you'll realize very quickly. Now, the best paper to tell you about the meaning of hemarthrosis, though, overall, I think actually is a paper like number 5. This is an early arthroscopy study in Holland. I'm not so much impressed with the concept of early arthroscopy, but why I like the study is because they really carefully documented what the injuries were. And so these are people with big hemarthrosis. A third of them had an ACL. Now, most of the literature says if you got a hemarthrosis, it's quite a bit more than that. But so anywhere from 70% of hemarthroses to 30% will have an ACL. A third had a meniscal tear. A quarter had a capsular tear. 20% had an osteochondral fracture. 13% had subsynovial hematomas, implying that the presence of, and I think that makes sense, a hemarthrosis, it's not just going to be the ACL. If we all acknowledge that there are multiple injury patterns in these, like the O'Donoghue's terrible triad, then a hemarthrosis would represent an injury to anything in there that bleeds. And so this kind of makes sense to me in terms of what you're thinking. And oftentimes you see things like in abstract 6 and 7, you see things like 193 lesions on 99 patients. Again, the reminder that multiple injury patterns are really, really common. Abstracts 10 and 11 confirm that in kids, you know the favorite line of the emergency physician for ragging on the pediatrician, you know what kids are? They're small adults. When they have a hemarthrosis, they have the exact same injury patterns that adults have. They don't have the same management, though. Particularly with lateral collateral ligaments and medial collateral ligaments in kids, because kids are growing and these are diffusely inserted and they heal pretty well, the management of collateral ligaments in kids is almost always, in fact, anyone who wants to do anything other than than conservative management of those in a kid who has some growing to do, you should regard that with some suspicion, because there's not much to do there. There's a bunch of papers here. Abstract 8, if you look at it, talks about how insufficient the clinical exam is. That's because they're talking about an acute knee. By the way, if you tap the big knee like that and you put bupivacaine back in, you can actually then examine the knee once you numb it up. Now I can do an exam if I really want to. So in that acute setting. But in the absence of that, it's really hard to do an exam. And if you talk to the orthopods about this, in an acute knee, if you want to do an exam, you either have to take them to deep sedation levels or general anesthesia if you want to examine an acutely injured knee. Now, if you do intra-articular analgesia with bupivacaine, you can get a reasonable exam, but it's still not quite as good. And the exam generally in the acute knee is insufficient. Now, what are some new exam techniques? We all know about Lachman's, and Abstract 12 tells you why the Lachman's is better than the anterior drawer for the ACL. Lachman's is generally perceived as better, and the reason is it's ergonomically better for you as a tester, and it's less painful for the patient as the examinee because the knee doesn't have to be fully flexed, and because the knee is resting on the table with you kind of checking for the anterior drawer element of it. And so the Lachman's, the reason I believe the Lachman's is superior because it's ergonomically better both for the tester and for the patient. And so that's kind of talked about there. Abstract 13 talks about 11 studies on the MacMurrays test, 4 studies on apnea compression, and says that they aren't particularly good. They have low negative predictive values. The positive predictive value is sort of okay and best for the MacMurrays of those 2 tests. So again, if you think those tests are 100%, even on a non-acute knee that has an injury, they're not that good. The new literature in the topic here that I think is kind of important, and I really like 14, there's 2 new tests, the Thessaly test and the EAGS test, 14 and 15. They both kind of involve the same thing, but the Thessaly test is a test where you put the person on their good leg like this, and you say, do the twist. And that really puts the femoral condyles and rocks them in the meniscus. And then you put them on their bad knee in the same way and ask them to do this, and you look for clicking and pain, and they say that this is a fairly sensitive test. You're looking for lock and catch and joint line tenderness, and that this will really help you identify some injuries. And I think I would look. I don't find the EEGS test as easiest to do, which is 15. I've tried them both. 14, the Thessaly test, I think, is really quite easy to do and helpful. So I would look at that if you're not familiar with it. Now, bunch of papers here talk about MRI versus the knee exam. Now, oddly, I just told you that the acute knee exam is not that good and that it's quite hard to reliably find these multiply injured patients. But then if you talk about the quiet knee, where you've let this cool off and you're going to do a quiet knee where an experienced examiner is going to look at it, you reach the opposite conclusion, which is that the knee exam is very good, which is kind of interesting. So, abstract 16 looks at exam under anesthesia being better in 19, and abstract 17 and 18 say the exam is still lacking, but then you go into a whole bunch of papers that talk about the exam versus MRI. And this is really important. I think almost everyone in here is aware that MRI is overused egregiously in this area. And part of the reason is because it's just a ka-ching factory over at the orthopods, right? You got your local orthopods, they got their 1.6 million Tesla magnet, and they're MRIing everything under the sun. They have a nice little mutual kickback referral process with their radiology group, and they're just going hog wild with it, consuming healthcare dollars. And here's what the papers on the topic say. Abstract 20 says exam is better than MRI in a quiet knee that's had some time to cool off. Abstract 21 says exam equals MRI. Abstract 22 says MRI is not routinely used. Abstract 23 says overuse of MRI. Abstract 24 says clinical equals MRI. And abstract 25 and 26 say MRI is not better than a skilled clinician. And then, so what is the counter argument for the orthopods? So basically the orthopods, it takes them a while. They don't read that much. So after we rag on them for about 10 years, they go, what him say? What him say about us? Must get publication to defend practice and twin-engine Beechcraft plane. Okay, so abstracts 27 and 28, and I really do appreciate the time they spend in the gym. But abstracts 27 and 28 talk about are the papers that if you're in an office-based practice, particularly this is more for the primary care people, if you're in an office-based practice and you're working with an orthopod with your people, the papers that they're going to talk to you about that say, oh, please stuff it. You know, I'm going to get my MRIs and you're not going to stop me from it. Never mind those 25 other papers. They're going to quote abstracts 27 and 28 to you, which are their papers that say that when you do an MRI, yes, of course we're going to examine them, and we're going to see the holistic person, not just the knee. I love the papers that come out of my institution, for example. Our orthopods did a paper on carpal tunnel syndrome, and there were 3,657 hands. We have no idea how many people were in the study. Honestly, you read the study, how many people? There's no way to even tell how many humans. You don't know. They wouldn't know either. They just looked at the hands. And that's, anyway, so the abstracts 27 and 28 would tell you that diagnostic certainty, and I think in emergency medicine I really appreciate this concept, that diagnostic certainty helps you avoid unnecessary testing. And so what their argument is when I've got someone who's been referred to me as an orthopod who's having ongoing knee problem that was serious enough to require a specialist, and I've examined them and think that they might have more than one injury in their knee, that when I MRI them, what I get out of it is increased diagnostic certainty and an ability to decrease the number of interventions I do and decrease the number of unnecessary, quote-unquote, arthroscopies. Now, of course, you might imagine that neither of these papers are written by primarily arthroscopy-directed orthopods, because the arthroscopers would tell you, skip the MRI and look at it with another imaging tool called the retina. It's a pretty good one. I'll use my retina to image the injuries through the scope, and that will be way better than all the magnets in the world. So obviously there's two sides to this, but you should know that 27 and 28 are the papers that defend them. How about comparison views? Are comparison views helpful in knees? People say sometimes on kids with growth plates and things like this, they can help you. Abstract 29 is an older paper. It's the American Academy of Peds position statement, Committee on Radiology, that says at no time should comparison views be considered routine. But that on occasion, if you really think it might help you with a Salter 1 or a Salter 5 suspicion, feel free. But recognize that when you do that, particularly in the elbow, for example, which is the last stronghold of the comparison view, remember those 6 growth plates, the crito, pneumonic, and all that. Even in the elbow, what happens when you get comparison views? Because the projection in the new comparison isn't the same as the affected side, because they're hurt, they're holding it kind of not right, and they won't put it in there right, it increases the number of false positives more than it increases the number of true positives. So you have to be very careful with getting comparison views, and they're not that helpful. You shouldn't do them routinely, except in one place, shoppers, it's a blue light special. If you're going to get an AP of one hip, you might as well get an AP of the pelvis. It's 2 for 1. Other than that, routine comparison views are not indicated. Then there's this paper 30 that talks about a horizontal beam lateral view of the knee, and what do you know about the line where the fat and the fluid come together. And it says that if the demarcation line between the fat and synovial fluid is below the upper border of the patella on a true horizontal beam lateral, then that tells you that it's an intra-articular fat pad and a fusion, not a suprapatellar bursal fat pad, not an anserine bursal flat fat pad, that it's actually in the joint. And so that if there's fat in the joint, then something's broken, because ligaments don't leak flat. And so if there's enough fat to create a positive horizontal beam lateral, and I don't use this routinely, most times you can tell what's going on without that, but there's a paper that tells you how to do it if you want to do it. And then the next question is on a knee, is an AP and lateral enough when you're getting x-rays of the knee, or should they get obliques and sunrise views? And abstract 31 says 2 views are enough. The only times I add obliques is, again, on a selective basis. Someone's got a knee that looks pretty bad. The obliques don't show me anything, and I think they have a tibial plateau because they won't bear weight. And their mechanism, they're hit by a car, is the usual story. And so adults who get hit by cars get tibial plateaus all the time because the bumper clips them right at their knee. And if I'm worried about that, and tibial plateaus can be sneaky. Tibial plateau fractures can clearly be sneaky, and it is one of the places where every once in a while you'll see people CT the knee to verify what's going on there. And so I will add obliques there. In terms of the sunrise view, there is not one paper that I found that really talks about a lot of utility to getting a sunrise view, because subpatellar problems and subpatellar chondromalacia is really more diagnosed on exam than it is radiographically. All right, decision rules. So next thing we have to go through is the decision rules. So we got the Ottawa knee rules. By the way, there's the Ottawa knee rules, we got the William Beaumont rules, the Stony Brook rules, the Pittsburgh rules, and the conclusion that I reach is that if you're cloistered in a snowy, really cold, miserable place for 6 months of the year, then you'll really have nothing else to do but to come up with rules. Now, having noted that, the rules are useful, and the Ottawa knee rules are good rules, but they don't save anywhere near as many x-rays as the Ottawa ankle rules. And the reason is, and we're going to talk about the Ottawa ankle rules in the next hour, and the reason is that in the ankle, if you've got an injured ankle and you've got a ligamentous injury, I really don't care. We're not going to do anything about your ligaments, so all I care about is fractures. And so the Ottawa ankle rules, if you don't have a fracture, I'm done. But with knees, that's not true. And so if I saw someone with a big knee, and they didn't have a fracture by the Ottawa knee rules, and so I didn't get an x-ray of them, but they had a big knee with a probable ligamentous injury, and I send them to an orthopod, am I going to save any x-rays doing that? What orthopod's going to do anything with them without obtaining an AP and lateral? I'm going to save no x-rays. And so while the Ottawa knee rules might save a few x-rays up front, it's really only on the boo-boo knees. Fall down kind of, I got a boo-boo on my knee, and and you're thinking they need nothing really but an ACE wrap maybe and some, you're going to fill up the outer electron shell with some Motrinos. If that's where you're at, then the Ottawa knee rule will help you. But for someone with a significant knee injury, they're going to get x-rayed. So let's just look at it. Abstract 32 sets the stage, says there's a lot of variance in knee x-ray ordering. The rule is age greater than 55, the proximal fibula is tender, the patella is tender, they can't flex 90 degrees, and they can't walk 4 steps. very similar to the other rule. So abstract 33, they derive the rule. Abstract 34, they validate the rule with a sensitivity of 100%. Abstract 35, they implement the rule and decrease the total x-rays by 26%. In my experience, it's more like 10%. Abstract 36, they externally validated the rule when they exported it to Emory Hospital. In abstract 37, in Spain, boy, in Spain they must have been doing a lot of knee x-rays. They decreased the number of x-rays by 51%. It worked in Belgium as well. And then whenever you have a lot of literature saying something works, you can get published because, you know, we academicians, we have to publish or perish that thing. So somebody will go, hey, I could just say it doesn't work, and they'll publish it. And so that's what abstract 39 is, a typical naysayer article. Abstract 40 says RNs, now this is kind of interesting and it doesn't make sense to me. Abstract 40 and 41 say RNs and mid-level providers have a hard time with the Ottawa knee rule. Now I don't get that because in the Ottawa ankle rule they do a great job. And I don't think the knee rule is any tougher, but it's kind of weird that it doesn't come out that well. So if you want to use mid-level providers, you could say. Abstract 42 I think is not true. Abstract 42 says you'll save $31 million in the U.S. on knee x-rays. As I pointed out, because you might save them on the first visit, but they're going to get them on the second visit when they go to the orthopod. So I just don't think the numbers and the savings are as great. Whereas in the Ottawa ankle rule, I think the savings are real. And abstract 43 is a paper that's in both of those chapters, which for the rule makers in Pittsburgh and those cold places, Ottawa and places like that, it has to be very disappointing, which says you can make rules, but really the lowly clinicians out there in their offices and in the ERs just don't listen to you that well. They don't take rules up. Even when rules are carefully derived, validated, etc., they don't do it, and that's what abstract 43 says. And so the lowly clinicians need to be basically, how do you get doctors to do what you want? You got to ride them, be there every day, tweak them, beat them, brand them. That's what abstract 44 says. If you do that, you can get them back to following the rules. And then there are the secondary rules, none of which I think merit much attention. But if you like any of them, if you want to know what the William Beaumont, the Stony Brook, the Pittsburgh rules, they're 45, 6, and 7. I personally feel that those secondary rules that were developed add nothing to the Ottawa knee rules. I mean, quite frankly, Ian Steele does the best job of deriving rules, validating rules, and keeping them fairly simple. Jerry Hoffman somewhere just rolled over and groaned. But in terms of the knee rule and the ankle rules, I think that they're better. And in abstract 49 and abstract 50 say that they work in kids. So kids' knees still pretty much the same. All right. Now we have just a few minutes to talk about some things that I think are really interesting, sort of more in an office-based setting, which are, should you do intra-articular steroids for osteoarthritis of the knee? That's abstract 54. It's a 10-study meta-analysis that says there is some prolonged benefit. Now, I don't do this. I work in an emergency room where people have no primary care. A lot of the people I see in LA County have nowhere else to go, so they come to the emergency intermittently. And so I'm often faced with asking these questions, which I'm a little bit uncomfortable with because I don't follow them. You know, if I was going to follow someone in an office in a family practice setting, I think it would be easier to say, all right, we've tried this, we've tried this, we've tried this, maybe it's time to go to steroids. It's hard to make that decision when I'm seeing someone really episodically with no follow-up. And so from an emergency medicine standpoint, I'm very hesitant to do these injections. I will do them occasionally, but very rarely. It's the exception. Now, on the flip side, if you read this paper and you are following people chronically, I think you might reach the decision based on this paper where on a selected basis you would feel okay about doing it. Abstract 55 looks at intra-articular hyaline injections. I think it's a weaker story. Abstract 56, I love this paper, and I love it because of how stupid it is. It talks about topical NSAIDs and how this is a brand new product. They have this Pensaid, which is diclofenac. Like they were the first people to think of transcutaneous aspirin. The very first ones. Now, Salon Pa has been available in any Asian health store for only, I don't know, 2,000 years? So that's all, it's the exact same stuff, costs nothing. So if anyone in here used Salon Pa occasionally? No one has used Salon Pa in here? You got to be kidding me. No one in here has used Salon Pa. S-A-L-O-N. space PAS. You can find it in any store. All it is transcutaneous aspirin with a little rubefacient like camphor or something in there to help it get across the skin. And if you go to some of these stores in Los Angeles, they'll mix it with DMSO for you. I'm not saying I support that, but now if you do transcutaneous aspirin, can you get a GI bleed from that? Yes, absolutely. You still have the systemic effects. They're a little bit less likely because they're having more local effects than GI effects. But Salonpa clearly works, and this paper, I just find it's like so far behind. And the FDA announced they were going to look at these transcutaneous products. I was like, haven't we looked at them for a century? I mean, they've been around at least that long. Okay, then we have a bunch of papers that talk about osteoarthritis and its management. And a couple things that say, we all know the whole COX-1 and the COX-2 story. I think we're pretty clear on that the COX-2s have their problems. Your knee will feel good, you'll just have chest pain. And then there's a bunch of papers down at the end here from abstract 60 through 67 that talk about glucosamine and chondroitin. Now, these are interesting papers. Part of the thing that's interesting about them is I got an old arthritic dog. The doggy literature on chondroitin and glucosamine is very good. The horse racing literature is very good. So on those animals, the animal literature is very, very compelling. The human literature, not nearly as compelling and much more of a wash. Now, my take on it is that over the last little bit, I think that people have been more willing to give these a try, and part of the reason is the people with chronic knee pain who've exhausted their other options, presuming they've exhausted the other safe options, where else are you going to go with them? And so part of your job is to give them some optimism and something that might, another passage, something that might work. And, so I don't have a problem with anyone trying them there. I would like them to be, one of the papers in there says that we don't know that much about safety. Abstract 67 says one of the issues with these is no one really has looked at these long term for safety, and so that they still need some surveillance for safety issues in terms of possible complications. And so I think that paper is important. And then finally, Abstract 68 and 69, this is really an emergency. These two papers are emergency medicine papers, and they remind us about, you see someone who's been in some autoped or some bad car wreck, and you're busy, right? They get intubated, they're going for their pan scan, they might get a chest tube, and maybe they're going to quick go off to a unit or to an operating room. When you look at those cases, particularly the ones that go to the unit, and particularly when they've been intubated, one of the common big dollar settlements against an emergency physician is 8 hours later, they got a pulseless foot. And someone goes, hey, what's going on with that foot? And then they go, well, his knee looks like it might be hurt, but the plane films were negative. But no one really, because they were busy, no one at any time in the secondary survey just did a little of this at the knee. And if they had, they would have found that that knee is completely unstable. They have bicruciate ligamentous instability, which means dislocated knee, which means check the artery, check the popliteal artery. And so we have, even at our institution where we do a lot of trauma, we've had a couple of these in the last decade. I would say I know of two, where so few patients go to the operating room anymore, right? They don't go for spleens anymore, hardly. They don't go for grade 1 and grade 2 spleens. They don't go for grade 1 and grade 2 livers. They don't go for mesenteric tears. They just don't go to the operating room anymore, blunt trauma, hardly at all. I mean, some do, but you either die or you live without a surgery. That's kind of where we've gone to with these, or interventional radiology takes care of you. And so what happens is then the only surgery that person needed was their knee. And so they get in a car accident, they end up in the unit intubated and end up with an amputated leg because their bicruciate ligamentous instability and popliteal artery injury is missed. And so it's a reminder to you in your multi-system trauma patients, for those of you who work in an emergency room, and for the practice people who may be involved as following these patients, to take a quick look at their knee and make sure that nothing's being missed there. Because if they have bicruciate ligamentous instability, abstract 68 and 69 tell you that's a major problem for them and might be the most serious injury they have.